Thank you, Natasha, and welcome everyone to Spotlight on Health. We're so glad you chose to join us tonight. We have a special guest, Dr. Robert Ostfeld. He is a cardiologist and the director of preventive cardiology. He earned his medical degree from Yale University and his master's in epidemiology from the Harvard School of Public Health. He completed his medical internship and residency at the Massachusetts General Hospital and his cardiology fellowship and research fellowship at Brigham and Women's Hospital, both teaching hospitals of Harvard Medical School. He founded and has served as director of the Cardiac Wellness Program at Montefiore Health System and as associate professor of medicine at the Albert Einstein College of Medicine. Welcome, Dr. Ostfeld. It's great to have you here this evening.
Well, thank you so much, Dr. Holly. Thank you for that generous introduction. Thank you, CNS, Ms. Lance, Max, and for everyone who is tuning in. It's a real honor to be here with you.
Yeah, we have a lot of questions for you tonight, Dr. Ostfeld. So everybody buckle your seatbelts and sit back and relax. Rob, tell us what your backstory is. How did you personally and professionally get into this plant-based approach?
Well, thank you. And, a lot of us, and I'm sure you as well, have very personal stories about how we came to be more plant-based. It's certainly not how I was raised or trained during my medical training years. I've always been interested in prevention. And when I was young, I had two brothers who died from an incurable disease, and that's kind of what got me on the path toward medicine and kind of prevention in general. One thing led to another. I became a cardiologist, and didn't really learn much about nutrition in medical school. And during training, I had the chance to work with lots of incredible people who taught all sorts of terrific things from pathophysiology to treatments to procedures and on, bedside manner, physical exam. But I learned very little even after medical school about nutrition. And I kind of knew when I was done with medical training that a Mediterranean style diet was good, but I couldn't really define it. And then I came down to Montefiore to do all the things I was trained to do, guideline-based medications, procedures, and I encourage people to have a Mediterranean style diet. And, people got a little bit better, but they didn't get like tremendously better. And so I was kind of getting disillusioned. Like I didn't go into medicine to get people a little bit better. And it was right around that time that I learned about the impact of a plant-based diet. Someone literally handed me the China study, and this was like in the mid 2000s. And being a myopic cardiologist, I just went to that like section in the middle. There's like short 8 pages or something about cardiology.
Yeah.
And I was really taken by it. And I used to run cardiology grand rounds at Montefiore for many years. So I got to invite the speakers. So I invited Dr. Campbell and Dr. Esselstyn and on, and lots of luminaries in this space, in part to learn more about it myself, but also honestly to drill it into our faculty, our whole division. And one thing led to another, and I thought, well, hey, if it's good for my patients, it's going to be good for me. And I gradually evolved, into becoming kind of by the late 2000s, fully whole food plant-based and haven't touched an animal product since. And started our cardiac wellness program at Montefiore. Like it kind of organically grew, but 2009, 2010, I think is when it like formally kicked off. And it's just grown organically ever since then with clinical, educational, and research arms. So it's really been just a terrific journey, and I completely rejuvenated me as a doc.
Yeah, it's interesting. I don't know if Dr. Campbell and his son Tom had any idea the impact the China study would have on physicians and the world and everyone, because I too am a result of the China study, and so it's amazing. So I always thank Dr. Campbell and Dr. Campbell for writing that book. It's had an impact on all of us. Yeah.
Yeah, that I guess that phrase, the butterfly effect, that there is a massive butterfly effect. I mean, so as you say, so many people have been touched in all kinds of meaningful ways by their work.
Yeah, yeah. So let's kind of start with a little bit of the basics for make sure we're all on the same page. Describe for our audience atherogenic cardiovascular disease. How do these plaques form inside our vessels? What's going on there?
Yeah, it's a great question and an incredibly important one because, of course, atherosclerotic related disease, heart attacks, strokes, the number one killer of adult men
Yeah.
and adult women in the US. And, like about one heart attack happens about every 40 seconds or so in the US. And women are about 6 times more likely to die from heart and blood vessel disease than they are from breast cancer. And now, clearly, you do not want either one, but it highlights the epidemiologic importance of cardiovascular disease for women. So, atherosclerotic cardiovascular diseases, atherosclerosis in the blood vessels, or another way of saying it would be cholesterol disease in the blood vessels in the body. And it's a systemic disease, and I'll get into some things that can cause it. But by systemic, I mean all over the place. This is not a disease that just affects one artery to the heart, it affects the blood vessels throughout the body. So if you have it somewhere, it's exquisitely likely that you have it somewhere else. And just so you know, I didn't figure this out myself, but apparently we have about, well, the circumference of the earth is like what, 25,000 miles? So apparently we have about 60,000 miles of blood vessels in our bodies. And
Wow.
I learned that from the George Washington University cardiology webpage many years ago. I took their word for it. But it just highlights like if we're healthy and you treat your blood vessels well, you treat every square millimeter of your body well. And if you kind of Google online these pictures of like just the arteries and the capillaries of your body, you'll see it's just it's uncountable. There's so many, every square millimeter like shapes the whole body. So you'll see how it just touches every square millimeter. So what happens is this is disease process that we can begin when we're very young. And I think Dr. Esselstyn put it pretty well. He's like, you graduate high school, you get a diploma, and you get heart disease, which is sad. But there are pathology studies that show that in our Korean and Vietnam War veterans and also trauma victims of more recent studies. People have it, in the prime of life in their 20s, so it's really quite sad. So what happens is that LDL cholesterol, or I should say more specifically ApoB, which is a type of protein on cholesterol particles, the most common one of those, that category is LDL by far. They will burrow into the wall of the blood vessel. And so if you think of the inner lining of your blood vessel, like wallpaper, like we have those endothelial cells that line the inner wall of our blood vessels. And that's kind of like wallpaper, And so what happens is these cholesterol particles burrow across the wallpaper, across the endothelial cell into the wall of the artery, where then they can become oxidized. So that makes them irritating like a splinter. And if you've ever had, a splinter, it's like all red and inflamed and annoying. Well, it's the same kind of thing, except it's in the wall of your artery where you want it much less. And what happens is, so I guess backing up a step, those endothelial cells, if you have enough LDL particles, they can just go across by diffusion. But those endothelial cells may, become injured with inflammation, pollution, smoking, toxic Western diet can make the endothelial cells less healthful, more prone to having cholesterol particles burrow across. And you would also, with an unhealthy diet, increase your cholesterol levels. And so this process, these LDL particles going into the wall, becoming oxidized, and when they do that, they create this whole inflammatory milieu. And what that does is it calls cells from other areas into the wall of the artery, other macrophages and smooth muscle cells in, creates more inflammation. The endothelial cells become less healthful, more cholesterol particles burrow across, and it kind of snowballs. And the process grows and grows, and suddenly a thin fatty streak can become the big plaque that's blocking a lot of the artery. And this is a process that evolves over years and years and years. So it's never too early to start to live healthfully. And of course, it's never too late either. And that transition from a plaque, so that process makes your arteries subtly less healthful also, but oftentimes in ways we don't really feel. But what can happen is all of that cholesterol plaque that's kind of like a pimple in the wall of the artery, it can transition into a heart attack or stroke. And what typically happens there is that wallpaper over time can turn into like a fibrous cap. And there's a fibrous cap that's the only thing separating all of that cholesterol grummus in the wall of the artery from the center of the artery where the blood flows. And you want that blood to flow well. But that fibrous cap with all the inflammation and oxidative stress can become weaker and weaker and thinner over time. And the blood's rushing by at every heartbeat, and it puts a little bit of shear stress on it. And that can crack with the shear stress and for other kind of interesting reasons, which we can discuss. But if it cracks, then all of that cholesterol plaque that had been in the wall of the blood vessel, making the blood vessel less healthy, but it can then get exposed to the blood. And that makes the blood clot. And sometimes the clot can be teeny, teeny, tiny, and you never know it happened, like a tree falls in the woods. Other times it could be a giant clot, block the whole artery. That's a medical emergency. You want to stent right away, and then everything in between. So that's a heart attack. And if you have that chest pain, chest pressure, shortness of breath, up into the neck, discomfort down the arm, call 911. Don't pass go. Better safe than sorry. Don't drive yourself to the ER. Call 911. But what happens over time if the plaque, the fibrous cap doesn't crack, the plaque can grow and grow and grow. And a whole big artery with a big opening for the blood to flow through can suddenly over time shrink and shrink and shrink and shrink to a teeny, teeny, tiny little hole. And so you may know people, they walk a couple blocks, they get chest pressure, maybe they take that pill under the tongue, gets the pressure goes away, then they walk again 2 blocks later, they get the chest pressure again. Well, that's the kind of thing they have now, a big cholesterol blockage in a teeny, teeny hole for the blood to flow through. And the heart needs that blood to feed it with energy. And when it doesn't get fed, you develop angina, so shortness of breath, chest pressure, symptoms like that. That's the kind of the 500-foot view of how we go from a healthy artery to one that's less healthful.
Yeah, excellent explanation, Dr. Ostfeld. Thank you for that, because a lot of people kind of picture, cholesterol building up in the lumen or the inner part of the artery. But as you explained, it's this cholesterol in the wall causing inflammation. And this, I like the pimple analogy. I use that as well. And this, over time, this pimple ruptures, and then we got to get a clot. So yeah, inflammatory process in conjunction with the cholesterol. Excellent. And speaking, people like to blame a lot of their health issues on their genes. They say, well, my father this and my mother had this and my uncle. And so what can we do to kind of turn the tables on our genes? Maybe we have genes that are more prone to heart disease. What can we do with lifestyle? Is cardiovascular disease amenable to lifestyle changes? And if so, what should we be doing?
Well, as you've taught me and many others, indeed, cardiovascular disease, particularly the cholesterol disease that's causing the trouble we just talked about, and many risk factors for cardiovascular disease, is very amenable to lifestyle change. And that's an incredibly important number of arrows in our quiver to combat this disease. Now, genes matter, but of course, lifestyle matters too. And it's all of the above to help protect someone. And there's a number of interesting and related studies. There's one really cool study where they looked at something like 26 different genes, and each one in and of itself raises heart disease risk a little bit, not a lot, but a little. But they looked at 26 of them, and they put people into thirds, like a low genetic risk, an intermediate, and a high genetic risk. And not surprisingly, those in the high genetic risk group did worse from a cardiovascular perspective. Okay, shocker. But what was interesting about this study is they further divided people into a poor, intermediate, and healthy lifestyle. And even in the high genetic risk group, if you went from an unhealthy lifestyle to a healthy lifestyle, you lowered your future risk of a cardiovascular event by about 50%
Wow.
in the high genetic risk group. But how did you get into the healthy lifestyle? Well, you had to exercise, okay, at least once a week. Well, imagine if you exercise 4 times a week. And you had to have 50% of your diet from a list of healthy foods. Well, imagine if you had 90% of your diet from that list of healthy foods. You would think that the degree of benefit will go beyond 50%. So genes matter, lifestyle matters too. And even in disease processes like familial hypercholesterolemia, where people can be walking around with LDL cholesterols 4, 5, 600, like
Hmm.
super high. Even there, and they'll sometimes be getting heart attacks in their 20s, possibly younger. They have clinical improvement when they adopt a more healthful lifestyle. So genes matter, lifestyle matters too, yeah. So
Yeah, yeah. So help us describe the framework for that healthy diet, that plant-based diet that you referred to. What do you consider whole food plant-based or plant-based diet? Tell us about the framework of that.
yeah, that's a great and important question. And so I considered a smartly or minimally processed plant-based diet where it includes tons of vegetables, particularly green leafy vegetables, fruits, whole grains, beans, lentils, chickpeas, peas, tofu, baked potatoes, particularly more colorful ones, salads. I'm totally fine with raw nuts and avocado. Then, doing your best to get rid of the junk food like cookies, chips, cakes, candy. And then, from my perspective, ideally eliminating, but at least minimizing animal-based products. And I see all comers in my clinic. So sometimes for me to get someone from who may be eating a typical Western diet to 100% whole food plant-based is a bit of a leap, and it can take a little while. So I'll take what I can get. But from a plant-based diet, it's what I described. And there is one supplement I unequivocally want people to take, and that's of course vitamin B12, because the B12 is made in the soil by microbes. And now, if let's say if you go buy spinach or something in the store, everything's like triple washed, so there's no soil,
Right.
so no B12. And animals get it because they eat soil or other animals that eat soil. But even now, all the pesticides and stuff, there's less B12 in the soil. So at any rate, I have people supplement that and monitor it over time. But that's the framework of it. And then, of course, we don't have it be one size fits all. Maybe some people have an allergy or a poor reaction to some kind of food, but that's the kind of general framework of it.
Yeah, excellent, excellent. Very, very clear. Thank you. Speaking of, you mentioned processed foods. Do foods high in processed sugars, like high fructose corn syrup and similar ultra processed foods, do they contribute to heart disease?
Yeah, I mean, absolutely. Those kinds of foods, in part, one important aspect is their unhealthful aspects, their lack of fiber, kind of empty calories, often high in fat, hyper palatable, doesn't make you feel full. Um, there's that. And then of course, it's instead of what? So you're eating that
Mhm.
instead of, I don't know, whatever, an apple or something that, you know, I don't know, granola cereal or something that would be healthier. So there are any number of studies that show that eating more ultra processed foods is associated with worse outcomes. And in all sorts of health metrics, including cardiovascular. There's one prospective cohort out of Framingham, Massachusetts. That prospective cohort there is pretty famous in medical circles. That's the cohort that actually put the term risk factor on the map. And there was an analysis of about 3,003 people in that cohort. And not surprisingly, the more ultra processed foods you ate, the worse you did overall. And from a cardiovascular perspective, I think each serving per day increasing risk by about 7%. Shocker, you eat more ultra processed foods, you do worse. But what was particularly, I don't know, shocking or alarming to me about that study is the average person per day had 7.5 servings of ultra processed foods per day.
Wow.
Like
Wow.
that's, I mean, what else do you have time to do? But so that was pretty shocking to me that much. But yes, it's not your health friend. Fine, have a treat every now and again if that's something that fits for you. But yeah, they're not your friend.
Yeah. Yeah. Excellent. So, Dr. Ostfeld, we often get questions from patients. They say, I'm doing everything right. At least I think I am. So address that patient that believes they're doing all the lifestyle changes to the maximum. No animal products, no processed oils, minimally processed foods, fruits, vegetables, whole grains, legumes that you mentioned, and they still have elevated LDLs and total cholesterols. Talk to that person and also answer the question, should these patients be considering statins?
Well, first of all, kudos to them for adopting the more healthful lifestyle. Our society is unfortunately not structured to make the healthy choice the easy choice. So kudos to them for facing down tons of ads, and I'm sure pressure from all kinds of random people in their life about eating differently. So good for them for doing that. That's awesome. And it's very likely that had they not been doing that, whatever disease process they're dealing with would be worse. So even if it's not perfect, it's likely. I mean, you can never tell on any one given person because it's a tough experiment to do. But it's very likely that whatever they're facing would have been worse had they not been having this more healthful lifestyle. But oftentimes, and I see this in clinic all the time, people are having a much, much more healthful lifestyle, checking the boxes, but still are facing health hurdles. And a number of things are important there. It's important to just press pause and you can review stuff with your doc, look in the mirror. Sometimes things sneak up on us. We don't realize we're eating something that we thought was healthy and isn't healthy, or we're not doing something and just didn't realize. So it's important to sort of take an inventory of that, just to be sure, because that certainly comes up. But if someone really is, they're eating a whole food, plant-based diet, they're exercising, they're getting good sleep, psychosocial support, among the other lifestyle pillars. And I even encourage my patients to floss or use a water pick once a day, because the link, as many of your viewers know, about periodontal disease, inflammation in the mouth, and a variety of disease processes, including cardiovascular disease. But so the It's really all of the above to protect people. It's lifestyle change and then medications when needed. And there are any number of medications, whether it be for high blood pressure or cholesterol or any number of things, that can do a lot of good. And unfortunately, there are a lot of loud voices in the influencer space who make like cholesterol lowering medications out to be the worst thing that's ever happened in the history of time ever. And that's so unbelievably irresponsible. They're obviously not for everyone, but they're incredibly well studied. They're better studied than aspirin. There are tons of randomized controlled trials where, for people who they are indicated for, maybe someone with higher cholesterol and coronary artery disease or atherosclerosis in their heart, they can do a lot of good and reduce risk over time. So it's sad to me when people kind of get sucked into the noise and they just don't use one of the very important arrows in our quiver to protect them. And we are, uh, medications can have side effects, obviously, but not taking a medication that's indicated has a side effect also, and that is putting you at risk. So, there's any number of ways to deal with potential side effects that statins may have. And your doctor will be extremely familiar with that. But we're also learning now that lower and lower cholesterol, LDL cholesterol, ApoB particles is better, to help protect people from cardiovascular risk. The and there are studies now, these are after the fact analyses of people who have a pretty advanced cholesterol disease in their heart using those injectable Repatha or Praluent cholesterol lowering medications. Those can lower LDL a lot. We use them oftentimes on top in addition to statins, or maybe if someone can't tolerate a statin, we'll use them instead, and they can get LDL cholesterols even down into 10 or 20, like super low.
Wow.
The equation kind of breaks down. We have to use different equation when they get super low. I've even had numbers come back at -4, and it's obviously ludicrous, but the equation breaks down at the very extremes. But anyway, super low. And in these after the fact analyses of these studies with people with very, very advanced heart disease, they just continue to do better the lower and lower and lower we get without seemingly having adverse events. And people are like, well, don't you need some cholesterol like for your brain? Well, your brain makes the cholesterol you need, not from going across the blood-brain barrier. And they did rigorous neurocognitive testing in some of these studies where they got LDL super low, not just some anecdote of someone who just like randomly forgot their keys. And those anecdotes, although powerful, can be quite misleading because oftentimes in life, around the time people starting a statin for vascular disease is when dementia, pre-dementia starts to show itself a little bit. So the fact that they misplaced their key just may be true and unrelated, a total red herring, but someone may take that anecdote, run with it, and not, use a medication that can be healthy for them. But in this rigorous neurocognitive testing, they did not find adverse neurocognitive effect. If anything, they may have found a slight improvement because it was associated with less stroke. And stroke can cause dementia, cognitive decline, obviously. And so we're learning that lower and lower is better. So these lifestyle changes, yeah, it's good for your cholesterol, but it's good for you for dozens and dozens of other reasons. So even if your cholesterol doesn't get super low, don't be discouraged because there's lots of other wonderful things you're doing for your body. And then using a statin to help yourself lower the cholesterol more. And sometimes we'll use other medications like ezetimibe, which can lower LDL another 18 to 20%. And there are graphs. Basically, the lower you get the LDL, the better you do. And however you get it lower, pretty much it's all along the same line. So medication A, B, or C, lifestyle A, B, or C, getting it lower, it kind of follows the same line. So you 100% absolutely, in my opinion, should be considering a statin with your medical caregiver. When indicated, they do a lot of good. And I would keep an open mind to using the full armamentarium of medications that are very well studied and we have to help protect you.
Yeah. So I'm hearing you say plant-based lifestyle, but don't be, phobic about using a medication because you can get down to that next level of protection.
100%, 100%. And it's such an important theme, and I'm glad y'all are highlighting it and asking about it. And it's really sad that it's become this conspiracy theory. I mean, they're generic drugs now. They cost pennies.
Yeah.
There's no, all kinds of people say, oh, the puppet of the drug companies. It's just made up nonsense. There's
Yeah.
no drug company out there telling me what to do. So it's sad. It's unfortunate that there's a lot of noise like that out there.
Yeah. Well, thank you for that very complete answer. You've mentioned apolipoprotein B. Tell us about ApoB and also ApoA. Are these markers that we should be paying attention to or not?
Yeah, I mean, they're both important. I'm assuming by A, you mean lipoprotein little a.
Correct. I'm
Okay.
sorry. Yes.
Oh, sure. And I just want to be sure I understood. So ApoB is a lipoprotein. It's a protein that lives on certain cholesterol particles, like LDL cholesterol, like triglycerides. And as luck would have, more like a fat, but anyway, that's insider baseball stuff. But like as luck would have it, there's one ApoB protein per each of these particles. And any of these particles that have ApoB are atherogenic. So if you measure LDL cholesterol, which is an important measure, and guidelines are, use them, you're not fully capturing the risk because you're not measuring every ApoB particle, because LDL will measure LDL, but it's not going to measure triglycerides and other types of particles that may have ApoB. Now, usually the overwhelming majority of these particles are LDL. The ApoB containing particles are LDL. So it's like oftentimes you're not missing things. But some people advocate to also, or in lieu of LDL, to get ApoB instead because it does, it's a better mousetrap. It gets a bit better of a picture. And that's quite reasonable. And you can use that to target therapy. So it is an important theme. There are people who very scientific academic people who feel quite strongly that at least in addition, but perhaps in lieu, should be used instead of LDL. And it does provide often additional information. So that is an important thing. And you with your medical caregiver can decide, is LDL enough for me, or do you want to also get ApoB? Both are still considered reasonable. Lipoprotein little a, it also has an ApoB particle on it. But usually the people have far, far, far fewer lipoprotein little a particles than they do LDL particles. Lipoprotein little a has been around forever, but it's only much more recently recognized, and it's really a bad actor. It can be quite pro-inflammatory. It can be quite pro-atherosclerosis. It may even make the blood clot a little bit more. And so it is now recommended that people have this measured at least once in their lifetime. It's felt to be about 90% genetically determined and about 10% by lifestyle. And we're still learning more. So higher levels are associated with worse outcomes from a cardiovascular perspective. And interestingly, from aortic valve disease, people are more likely to develop aortic stenosis or a tight aortic valve when they have high lipoprotein little a. And that may be from those particles depositing around the aortic valve, causing extra inflammation. We don't actually know for sure if lowering lipoprotein little a is helpful. We think it is, but we don't know for sure. And we do not have a medication that can meaningfully lower lipoprotein little a currently that has shown to have benefit for that. There are a number of studies ongoing now. The one most close on the horizon to being reported is the Horizon study, where they have a medication that specifically lowers lipoprotein little a. And they're studying it in people at risk, and it's supposed to report this year. I don't know when. It'll be like front page, New York Times, CNN, that kind of thing. You'll hear about it. And so we'll know these medications can lower lipoprotein little a lot, some of them 60, 90%. And so we'll learn whether lowering it is or is not helpful. We think it is. And interestingly, those injectable LDL cholesterol lowering medications can lower lipoprotein little a by about 25%. So sometimes we'll use it also for that reason, but we don't honestly know for sure if that is or isn't helpful. We just think it is. But it's a bad actor. A level higher than 75 nanomoles per liter. Some people use say 50, is associated with worse outcomes. And when it's elevated, we don't have a medication for it. What we use it for is to reinforce the importance of a healthy lifestyle. Because sometimes when faced with that type of headwind, people may be more motivated to pursue lifestyle change. And we also use it because we want to optimize all optimizable risk factors when we have an elevated lipoprotein little a. And we'll sometimes use it if we're on the fence on someone about whether a statin may be helpful. We call it a risk modifier. And we say, well, gosh, no, you're on the fence, and then this is high. So that tips us over on the fence to the side of using a statin to optimize the LDL aspect of things. So they're both very important. They're, can be discussed with your doc. Your doc should be familiar with them at least. And it's a simple blood test to check them. And stay tuned. There's going to be a lot on the horizon about lipoprotein little a. Probably 2 years. There are like 3 or 4 major studies in the pipeline. But Horizon Hope, I wanted to report already. It's been a while.
Yeah. Yeah. Thank you. So I guess in the meantime, while we're waiting, optimize your lifestyle and pay attention to lipoprotein little a when it comes, when the studies come to light.
Yeah, I should say there is a little bit of data that a plant-based diet in a small case series by Dr. Najjar and the late Dr. Baxter Montgomery, they found, and it's a case series, so it's not the strongest category of evidence, but a plant-based diet in their study lowered lipoprotein little a by about 16%.
Mm.
But there's also randomized short-term data that an animal-based keto diet lowered lipoprotein little a. So but it raised other things. So I certainly don't want my patients on an animal-based keto diet. So let's wait for the big studies with thousands and thousands of people so that we can get a better understanding of the lay of the land.
Great advice. Dr. Ostfeld, why do so many people end up on blood pressure medications and often on more than one? I see patients in their, 20s, 30s, 40s on one, two, three, four blood pressure medications, and their blood pressure is still elevated.
Yeah, it's a real issue. It is I think the number one modifiable risk factor. It's high blood pressure is quite deadly. We call it the silent killer because you don't feel it, but it can kill you. And it could increase your risk of stroke, heart attack, heart failure, kidney disease. You don't want it, obviously. Um, Interestingly, this statistic, every time I read it, I can't believe it. I have to relook it up because I think I'm mixed up. But from data from the Framingham Heart Study, if you're like a 50-year-old adult in the US, your lifetime risk of developing high blood pressure is like 85%.
Wow.
It's insane. It's so crazy. And the average person in the US is on 2.5 blood pressure pills to get their blood pressure normalized. And we're learning that lower and lower blood pressure is better from any number of randomized studies and supplemented by epidemiologic studies. So the numbers may go up because, we want to protect people. There's a really interesting group of people, the Simane people. They live in the jungles of Bolivia. And there's a really awesome article about them in Lancet. I think it's published in 2017. They have the lowest rates of heart disease ever recorded in the medical literature. This study, they got CAT scans, and they described, I think about 700 of them. They're an indigenous population. Their diet, they exercise, they're really active. They hunt and gather. They're active 11 hours a day, more. Their diet is 72% carbs. That's complex carbs, like tubers and stuff. I think it's whatever I'm messing up. Like 14% protein and 14% animal fat, and 14% fat, and the animal products they're like eating wild monkeys, presumably the healthiest kind of animal food you could get. And they have the lowest rates of heart disease in the world. Also, incredibly low rates of diabetes. Mind you, their diet is 72% carbs. Thank you very much. Carb
Yeah,
is not a four-letter
that's
word,
right.
as you all well know. But their rates of high blood pressure are an order of magnitude lower. Um, this is kind of off the top of my head, so so I apologize if my numbers are a little bit off. But like for those over like 70, I think something like 9 or 10% of them total had high blood pressure. It might be lower, maybe 8%. So it's just so much lower with a healthier lifestyle. And interestingly, this group of people has a lot of inflammation because oftentimes they're walking around barefoot and getting infections in their feet. So, despite that, much lower heart disease. They're, in fact, compared to an epidemiologic study of the US population, their vascular age is about 25 years younger.
Wow.
Yeah, compared to
Impressive.
MESA, the multi-ethnic study of atherosclerosis. MESA. But so they have much lower rates of high blood pressure. So there's a genetic component. I mean, there certainly are some genes and things that can lead to high blood pressure, no question. But there's a lifestyle component too. Diet, exercise, alcohol, sleep apnea. When I was in med school forever ago, there were lectures. Sleep apnea is when the airway closes some when you sleep, and that's extremely physiologically stressful on the body, can drive up different neurohormones and drive up blood pressure. So what happens when you snore, the airway closes a little bit, you make the snoring noise, but sometimes it can close too much. And that can happen particularly when people are overweight. But I don't know, like a not small percentage happens even in normal weight people, but most of the time it's overweight or obese. And when that happens, but the airway can actually close. You stop breathing and you have all these microarousals. You may not actually wake up fully, but you'll have microarousals. You don't get restful, healthy sleep. It raises all kinds of stress hormones in your body. It can long term raise blood pressure. And when I was in med school forever ago, there were all these lectures about how sleep apnea is under-recognized, underdiagnosed. And if you walk around med schools today, there are lectures about how sleep apnea is under-recognized and underdiagnosed. It's like nothing changes. So, that can be screened for. And there's any number of things like hyperaldosteronism, which is highlighted in the brand new hypertension guidelines that just came out like a week ago. But so, lifestyle plays a huge role. Diet through the DASH dietary approach stop hypertension can lower in some cases like 10 points the systolic top blood pressure number. Less alcohol can do it significantly. Exercise, sleep. So there's all kinds of lifestyle things that you can do, can go into it. And since 0.7%, according to an analysis of another data set representative of the US, the NHANES data set, 0.7% of the US consumes a quote ideal diet, and 72% consumes a poor diet. It's not overwhelmingly surprising that poor diet related things are common, like high cholesterol and high blood pressure. And obviously genes matter too, but so I think that suboptimal lifestyle profoundly contributes to that. So that's why, and people will require oftentimes multiple medications to lower it. Because as you know quite well, these blood pressure medications are good, but they're not necessarily going to lower your blood pressure 40 points, maybe 5, 10 points, and then you're not quite there. Then there's another medication, et cetera. In fact, it's even recommended now to start a combination pill with 2 blood pressure lowering pills simultaneously because it's so common for people to be on more than one.
Yeah. Yeah. And I always encourage people when they're making lifestyle changes and they're on 1, 2, or 3 blood pressure medications, work with your doctor because you're going to need less medication. Otherwise, they start feeling lightheaded and dizzy. They say, oh, this plant-based diet is making me dizzy. No, it's all that blood pressure medicine that you don't need it anymore. So,
That's
yeah.
100% correct. I've
Yeah.
seen people I've seen people have them say that their doc told them to eat more salt, and
Oh, goodness.
just totally 180 degrees backwards.
Yeah, yeah. So, Dr. Ostfeld, tell us about atherogenic erectile dysfunction. Is it treatable with a nutritional approach? And also tell us about some randomized control studies that you're participating in.
Well, thank you. Yeah, I mean, erectile dysfunction, there's a bunch of different causes of it, right? There's neurohormonal causes, There are, it could be trauma, there's psychologic, some side effects of medication. So, but from atherosclerosis, that's by far the most common in the Western world. And we call ED, erectile dysfunction, the canary in the coal mine for heart disease, because by the time you have cholesterol disease impacting blood flow into the penis, it's overwhelmingly likely, because it's a systemic disease, that you also have it in the blood vessels that are feeding your heart with blood, but it hasn't yet quite manifest clinically. And why is that? Well, the artery to the penis is smaller than the arteries to the heart. So when you have a blockage in the artery to the penis that's causing decreased blood flow, you probably have one in the heart, but it just hasn't clinically manifest yet. And ED typically presents 3 to 5 years before heart disease does. But the good news is the healthy lifestyle measures that improve risk factors and can help with atherosclerosis in the heart can improve blood vessel function throughout the body. And it does appear that, yes, indeed, a more healthful lifestyle can improve erectile function. There are randomized studies of Mediterranean style diets, which is largely a plant-based diet, versus a more typical Western diet, where over time people improve their erectile function. With a Mediterranean style diet. Exercise is important as well. And we have this is anecdotal, but we have tons of clinical experience in our office where when people adopt more plant-based diet, their erectile function also improves. We actually presented a case of it at the American Society for Preventive Cardiology, and it was accepted for publication in the American Journal of Lifestyle Medicine, but it hasn't been published yet. It'll probably be out in, I don't know, next month or so. But yes, absolutely, a healthy diet can help prevent and improve that. And we have 2 randomized trials going on right now looking at the impact of dietary pattern on erectile function in young, healthy men with normal erectile function, looking at a plant-based diet versus an animal-based diet, and we're using this device called Rigiscan. People may be familiar with that because they use that in the Game Changers documentary. So people are wearing that, and we're studying that in a scientific way, and we'll see what we find. If people are interested, please, trying to think, if you live in the New York area, I'll send a copy of our contact information that can go into the email that goes out later about this podcast. Where if you're in the New York area and you want to be a part of it, you may be eligible. We would have to screen you, but we're looking to get more participants, and we pay participants whatever the rate that the IRB lets us. So yeah, we have, for our first study, we have 30 out of 46, so we need 16 more still. And our second study, I think we have 10 out of 30. So please participate if you're in the general New York area, close to the Bronx.
What's the age group that you're studying?
They're a little bit different, each one, but basically 18 to 35.
Okay. Great. You also mentioned some other plant-based initiatives that you've been working on. One in particular you said is, quote unquote, at the 1 yard line. Tell us about those initiatives.
Well, thank you so much. I feel fortunate to work at Montefiore. They've given me space to do a lot of things in this arena, and it's totally aligned with their mission. Over the years, we've done a bunch of different initiatives, and our plant-based program has a pretty robust clinical arm, a research arm, and an educational arm. And the research arm is those 2 randomized trials, and we get to be involved with review articles, case reports, case series. That's wonderful. But specifically at Montefiore, we of course, many years ago, developed plant-based meals that are available for inpatients. We describe that in the International Journal of Disease Reversal and Prevention. We have the documentary film Forks Over Knives playing on continuous loop on one of the inpatient educational channels, and those plant-based meals are also served in the cafeterias. We weave this educational aspect into a lot of what we do at Montefiore. Montefiore owns the medical school, Albert Einstein College of Medicine, and I get to teach the medical students required preventive cardiology talk each year. And of course, weave plant-based nutrition into that discussion. I teach residents and our fellows. Our cardiology fellows now put in their consult note just above assessment and plan, does the patient consume at least 5 servings of fruits and vegetables a day? Yes, no, deferred. So they're required to put that in and answer one of those three things. Obviously, if someone is intubated and not speaking, they can't ask questions, so that's deferred. But I put it there so that it'll be drilled into our fellow's head. And if they're talking to our patients, the patients will realize we think it's important. And then, of course, anyone who reads the cardiology note, and any physician here knows that if it's right by the assessment and plan, that's good note real estate, and they'll see it. If it's in the middle, they probably won't see it. That's why it's there. We want to get our plant-based meals used more frequently for inpatients. They're not used as much as they could be, unfortunately. It's optional to order them. And so Montefiore is a huge system. It employs like 30,000 people, has 11 hospitals. There's only so many talks I can give, so many floors I can go to. And so we created, this is at the 1 yard line, and now it's in the end zone, but it's further being refined. So we created this 15-minute video that is going to go on, that's now on the Montefiore internal learning channel. Those of you affiliated with medical systems know that you probably have your own internal educational channel where you have to watch required videos for credentialing and recredentialing, all about all sorts of things. And now our 15-minute video, which is about the why of a healthful diet, largely plant-based, and technically how to order it in our electronic medical record and talk about it with patients at Montefiore. Quite specific general educational information, but quite specific instruction about how to order it, is now on there, and it's going to become required viewing for all incoming house officers, meaning residents, fellows. There could be 1,500 of them a year and throughout the system, starting this upcoming July. After, then after July, they kind of dissipate. So starting this July, it's probably going to be required viewing from all physician associates, PAs. That is, we're discuss setting that up right now. There's probably more PAs than there are house officers. It might become required viewing for all nurses. I don't know for sure yet, but it's going to somehow be encouraged. And then we'll see how it goes with attendings. At a minimum, it's going to be strongly encouraged. So I'm very excited about this. It's going to help, hopefully raise the bar throughout the system, get the plant-based meals ordered more, do a lot of good for patients, and all kinds of other things. So that's one that's been a labor of love, but it's it took a little while to get from here to there. So I'm
Yeah.
very, very
I
happy
mean,
and very proud of it.
yeah, that's very, very powerful. And you said they can order a plant-based meal. A lot of hospitals don't have that.
Yeah, it's sad. It's unfortunate. I think only, I mean, I don't have my finger on the pulse of the laws. I think only New York and California now have laws where you have to have at least have a plant-based option
Hmm.
for patients. I don't know that other states have that law. But at any rate, I'm glad at least two of them do. But it's unfortunate, and it's a wonderful. I mean, it's basically a teachable moment. People are, you've got their attention. Hopefully, this is a time when they'll reassess some healthful lifestyle choices and maybe choose a more healthful path. And like it's on us to help them do that.
Yeah, yeah. Dr. Ostfeld, we have about 3 or 4 minutes left. Do you have a patient experience that maybe our audience would find useful that you would share with us?
Yeah, I mean, there's so many, and it's really turned me around and reinvigorated me as a doc. I mean, I've seen so many things improve. As you've seen too, come off multiple blood pressure medications, cholesterol plummet, um, the erectile function totally reverse, erectile dysfunction totally reverse. People come off diabetes medications, profound weight loss. It's, people that cry tears of happiness. Typically, when people go plant-based, something that wasn't even on our radar gets better. Like, oh, that chronic skin thing that I had or that ache I
Mm.
had, it's kind of better. It wouldn't even occur to us to discuss it. And then all of a sudden it's better. Like, we've published a number of cases in the literature about stuff. And there's one that I talk about a lot in my talks This is one we saw very early on. He was a 60-year-old gentleman at the time who was getting chest pain, sometimes sitting still or walking a block or two. And he saw his primary care doc, and they did a stress test, and the stress test was positive. And of course, it's only in medicine that the word positive means something bad. But that basically means he has cholesterol disease in the blood vessels in his heart. That's causing the blockage. And this particular gentleman, his blood pressure was a little too high, his cholesterol is quite high. But he didn't want to take any medications, have any procedures. And he's the boss. An informed patient is the boss. And in fact, and obviously from a medical perspective, we would want him to use all the arrows in the quiver, medications and lifestyle, maybe procedures if necessary, but certainly medications and lifestyle. And I presented this case at the American College of Cardiology meeting years ago, and like some of the cardiologists in the audience got up and yelled at me later, like, why didn't you get him on a stat? I'm like, well, I can't force him, like that's assault. So like, I don't know, like, you can tell him, you can describe, you can show him the evidence, but at the end of the day, the patient's the boss. Anyway, so fast forward a few months, he could walk, now from 1 to 3 blocks, he could probably walk 20 minutes and stop, and his LDL fell 70 points, his blood pressure normalized. Fast forward a year, he could jog like a couple miles. And then I saw him just before the pandemic, and the guy would jog 4 miles and stop because he got bored. And that was just the power of lifestyle change. So it's really wonderful. And I'm so glad. I mean, Colin Campbell, his son, the work of CNS, all of you have such unbelievable butterfly ripple effects. And of course, you want to do it with the care and following of your team, of your medical team, of your physicians, because sometimes people have an allergy to something, sometimes people have an adverse this or that, and you want to be followed. But from a 500-foot view, the work that CNS has done, Dr. Campbell, all the Dr. Campbells have done, it's just incredible. And Colin Campbell is in the on the Mount Rushmore of plant-based nutrition. He's an incredible inspiration to me, to our program, and I'm so grateful to have worked with him, to know him, and to have been a part of CNS.
Thank you. Thank you for those great comments. Dr. Campbell is our hero. And yes, he belongs on Mount Rushmore. Yeah, you're right. You're right. So while Natasha's coming in and she's going to give you some questions from our audience, I have one question from the audience that I didn't get to. And you alluded to a little bit, but this is a patient who didn't have any health issues, but they decided the best course ethically and for their health was to go plant-based. So they went plant-based, but and we kind of talked about this earlier, but this person in particular says, my cholesterol, we didn't plummet. She said, there's other people that say their cholesterol dramatically changed when they go plant-based, but this patient's did not dramatically reduce or plummet. What would you say to that person?
I would say awesome job eating and living more healthily. Kudos for you to be able to turn it around without facing a major health hurdle. And I wouldn't be discouraged at all. We see this, not uncommonly. Some people, their LDLs plummet, some a little bit, and some don't really move. And when they're, eating and living much, much more healthfully. And if you look online, like people don't share on Facebook, oh, hey, I went plant-based and my LDL fell 6%. Like people aren't sharing that. They're sharing like, hey, it fell 10 million points. Like that's what gets shared. So there's like a skewed sample out there. But there's a genetic component to cholesterol, and you just may have a higher genetic floor, but there's all kinds of other benefits. And like I like to do this thing, we get this CAT scan, right? Looking for something bad. Well, so I figured, why don't we look for something good with plant-based nutrition and call it the CAL scan? So eating more healthfully before getting into the CAL scan, anti-inflammatory, antioxidant, high fiber, feeds the microbiome, all kinds of wonderful things. Cholesterol is one of dozens and dozens of wonderful things it does. So I wouldn't get discouraged at all. And with the CAL scan, it's associated with less depression, less stroke, less cognitive decline, better complexion, less heart disease, less lung disease. less cancer, less obesity, less diabetes, less inflammation, improved sexual function in men and women, improved athletic performance, among other things that I'm just forgetting right now. So I wouldn't be discouraged at all, less high blood pressure. Wouldn't be discouraged at all. And unfortunately, that does happen sometimes. And, sometimes medications are necessary.
Yeah. Beautiful answer. Welcome back, Natasha. You
Thank
have some
you.
questions. You have some questions for Dr. Ostfeld?
Oh, I certainly do. People have been busy asking some excellent questions. Let's start off with one that I hope you will be able to answer right off the top of your head. And that is, at your hospital system, do you have a support group or programs for patients after they complete cardiac rehab?
After cardiac rehab, it's really following up with your doc. They'll different clinical groups may have smaller things. What we have in our cardiac wellness program is I have these periodic Saturday morning sessions that are 2.5 hours long. I used to do them in person for much longer, serve lunch, but with the pandemic, that went away. So we do them there, and I speak, and RD Lauren Graff speaks about the how and why plant-based nutrition. We have 30 minutes of Q&A. So that's a support group we have. There are other kinds of support groups that different individual pockets of people have. But after cardiac rehab, not that I'm aware of formally on a very, very large system-wide level, which is a shortcoming.
Gotcha. Thank you very much. So you talked very early on today, and some people kind of joined us a little bit late, I think. We have folks on the call tonight who are on the Zoom call who are not real familiar with whole food plant-based, and then we have some people who've been plant-based for a long time. Someone's asking, what foods can we eat more of that are the equivalent to taking a statin? You did a great job of explaining that at the beginning. Could you kind of reiterate what foods should people be eating?
Every little bit counts of eating more healthfully. And if someone wants to go 50% of the way there, hey, it's better than 20%. So I'll take it. And we don't have to have perfection be the enemy of good. And we don't have to have, I'm not saying we do, but sometimes there are circular firing squads where someone is an extra, extra, extra perfect. They kind of get a little bit ostracized, but every little bit counts. And even 3% can count. There are studies that show that 3% replacing animal protein with plant-based protein. Dr. Song, 2016, Archives of Internal Medicine. I think JAMA Internal Medicine. Yeah, JAMA Internal Medicine. But so a plant-based diet is tons of, we call it minimally or smartly processed, tons of vegetables, fruits, whole grains, beans, lentils, chickpeas, peas, tofu, baked potatoes, salad, raw nuts, avocado. So that is kind of like the umbrella of things. Lots of herbs and spices. Now, in terms of diet lowering cholesterol, statins are important too. I would encourage people to keep an open mind to think of it as not either or rather all of the above. But from a dietary perspective, there's wonderful work from Dr. Jenkins out of Toronto with his portfolio diet, which is basically a high fiber plant-based diet. And a high fiber plant-based diet in randomized controlled trials can lower LDL cholesterol about 29%, which in that same randomized trial was just minimally less than a minimally potent statin, a low potency statin. And that one, it was, I think it was Mevacor, lovastatin. Sorry, it was lovastatin 20 milligrams. And I think that lowered it about 33%. And the high fiber plant-based diet lowered it about 29%. So, that can be incredibly effective and helpful.
Wonderful. Thank you so much. We've talked about some of the things that are most on people's mind related to heart, but there are a couple of things that weren't mentioned this evening that I think are worth bringing up. And one of those questions is spelled out here. Is AFib curable with diet and other natural means? And is it hereditary? So maybe starting with a definition of what is AFib for those who don't know. And then, can lifestyle and diet affect that? And then also, is it hereditary?
Atrial fibrillation it is an abnormal heart rhythm that can increase your risk of stroke. The heart has 4 chambers. There are 2 atrium on top, and there are 2 ventricles on the bottom. Normally, the atrium contract in an organized way, push blood to the ventricles, which then squeeze and push blood to the lungs and body. And if you feel your pulse in your wrist, every heartbeat, you feel your pulse, every pulsation you feel is the ventricle squeezing blood to your body. So, but sometimes, whether it's from long-standing high blood pressure, suboptimal diet, etc., the atrium may get a little sick, the top two chambers, and instead of contracting in an organized way, they jiggle. And they don't contract in an organized way. Who cares? Well, when that happens, blood can pool on the wall, pool in the atrium, and develop a little clot. Break off, go to your brain, go to your kidney, somewhere in your body where you don't want it. And usually the strokes from atrial fibrillation are pretty big and pretty devastating. So it's a real problem. But fortunately, lifestyle stuff aside for a second, we give people blood thinners, like people may know Coumadin or Eliquis, things like that, blood thinners to help reduce the risk of stroke. And sometimes people's heart rates can go very, very fast because there's a lot of chaotic electrical activity in the atrium. And we'll give them medications to slow their heart rate down. And there are also invasive procedures to help get someone's heart rhythm back to quote normal. So lifestyle does not cure atrial fibrillation. Lifestyle is not a replacement for blood thinners for atrial fibrillation. If you use that, you're putting yourself at risk for a stroke or a complication. So full stop. Now, lifestyle, absolutely healthy lifestyle can reduce the risk for atrial fibrillation. Losing weight, keeping your blood pressure lower, keeping your vascular system healthy can lower one's risk for atrial fibrillation. We also know that after someone's heart, after an ablation procedure to get someone's, it's the Legend trial out of Australia, get someone's heart back to a normal rhythm, weight loss, I think it's 10% or more, can reduce recurrence of atrial fibrillation. It's just weight loss in general. So a healthy lifestyle, we think, will reduce your risk of developing it. And if you get shocked, if you get converted back to the normal rhythm, you make you more likely to stay there, albeit not perfectly. And of course, it's healthy for you overall, but it absolutely does not cure atrial fibrillation, and it is not a replacement for a blood thinner when indicated.
Thank you. That was very clear. Could you address the hereditary component?
Oh, yeah. There is a hereditary aspect to it. Some atrial fibrillation can be hereditary. There's also a huge lifestyle component to it, and these things get tough to tease out because not only do genes run in families, but lifestyle runs in families, so it's tough to tease that stuff out, but there are some genes that are associated with atrial fibrillation. Yes.
Thank you very much. Another question was posed when it comes to heart attack. What are the differences in the symptoms of heart attack between women and men? Could you define that for people?
Sure. So the most common symptom, the symptoms were originally defined in men, which is kind of unfair. But the most common symptom is the most common in men and women, and that's chest pressure, chest pain, pressure rating up to the neck, down the arm, shortness of breath. That's like, out of the blue, but palpitations. But in women, they tend to have a broader array of symptoms. Palpitations may be more common for them. Lightheadedness may be more common for them. Shortness of breath may be more common for women than men. So you have to cast a wider net. So if you're feeling a symptom that's strange, out of the blue, but it's not just a crushing pressure on your chest, it is possible that's a heart attack. And if you're a woman, we have to be keep that particularly top of mind and take it very seriously. If there's some reason you're concerned that you may have that, ask questions later, call 911. Time is of the essence if that's happening. But yes, the definition was, it was originally defined in men, and the most common symptom in men is the most common in women, but there's a heck of a lot more in women, much wider net.
Okay, thank you very much. Someone asked if they've read that statins increase LP little a. Can you address that?
Yeah, that has been seen.
Okay.
Might increase lipoprotein little a. But despite that, people still have benefit. In dozens and dozens of huge randomized trials, statin versus not people, or statin on top of other things, people are having benefit. So I would not, if the statin is indicated, I would not have that concern stop you from taking a statin. And I use statins for my patients in general, and when indicated for my plant-based patients as well.
Okay, thank you for making that clear. Do you see an increase in LDL in postmenopausal women who previously had wonderful lipid levels?
It can go up post-menopause. There's a variety of physiologic changes that happen. Vascular function may worsen, blood pressure may go up, cholesterol may become less optimal. So absolutely, that's an important time to reassess risk factors, be sure you're having as healthy a lifestyle as possible, talking with your doctor about what to explore. But yes, that can happen.
Okay. And we have a couple more questions and then we'll be done here. So this is a question. Let me find it here. Why do arteries sometimes get 99% blocked, but they don't rupture? Is that a
Yes.
true statement? And why is that?
So typically the cracks or rupture, the plaque cracking, the fibrous cap cracking, the pimple erupting, that typically happens in smaller plaques, 30, 20% lesions. Because by the time a plaque gets to be, these are rules of thumb, it's not, absolutes. But by the time a plaque gets to be 95, 99% blocked, that's grown slowly, it becomes thickened, it's calcified, it's socked in there. It doesn't necessarily have that thin fibrous cap that's about to crack. So it gets really socked in. And those can cause angina. And it's very likely if you have some 90% lesions, you probably have a bunch of 30% lesions all over the place too, because these things go together. But it's typically the smaller ones that cause the heart attack because they have the thinner fibrous cap, more prone to cracking.
Gotcha. Thank you very much. Now, this one is, it's kind of specific, but obviously someone is wondering this and others may be. How is SCAD or SCAD, spontaneous coronary artery dissection, caused? Is it addressed by lifestyle and diet?
I don't think we have enough data to say that unequivocally that it's addressed by lifestyle and diet. I'll give you my hypothesis is yes, because now the reason that we get it is that there is a tear, kind of a spontaneous tear in the endothelial cells, and blood can then burrow under that into the wall of the artery, and often into the media part of the wall of the artery. And high blood pressure can predispose to that. Sometimes people can have connective tissue disorders where the collagen, the structural fibers in their body may be a little bit weaker than normal, and that can predispose them to having these kinds of tears happen. And so, so what happens is blood rushes by, and for whatever reason, there's a structural abnormality, there may be weakness, or maybe higher pressure from high blood pressure, and that will cause that tear. And blood will then burrow into the wall of the artery and extend and cause the spontaneous coronary artery dissection or dissection somewhere else in the body. And that can cause a heart attack. I think that a healthy lifestyle, keeping the blood vessels as healthy as possible, lowering blood pressure, makes sense that it would be helpful for SCAD. I'm not honestly aware of any robust lifestyle data in SCAD. If somebody knows, please email it my way. I'd love to know, but I'm not aware of good data about that.
Okay. Thank you so much for your time. We could go on for the next 2 hours, but yes, we really appreciate you being here this evening. I just want to reiterate that the replay of tonight's session will be available 1 week following today. So next Tuesday, everyone who is in attendance or who registered will receive a replay as well as a follow-up email with some resources attached. So with that, I thank you very much, and I turn it back over to Dr. Michael Hollie.
Thank you, Natasha. And thank you, Dr. Ostfeld. This has been beyond excellent. Your expertise, your skill at answering difficult questions, and making the answers valuable, useful, practical. Thank you so much. It's been excellent.
Well, thank you so much for having me. It's an honor to be here with you today, and I'm so honored that people have joined this call.
Great. And join us next month, September 9, correct, Natasha? Is that our date?
Mm-hmm.
Yeah, next Spotlight on Health is September the 9th. And we will have, some of you may recognize the name Chuck Carroll. Chuck Carroll, the weight loss champion, is going to be joining us and giving us a lot of great information. So look for your emails soon on that. So on behalf of the T. Colin Campbell Center for Nutrition Studies, this has been Spotlight on Health. We're so glad you joined us, and we'll see you next month. Good night and goodbye.